Hello, everyone. Good afternoon. I'm Karen Scott, president of the Foundation for Opioid Response Efforts, and it is wonderful to welcome you all to our webinar today. It's been a little while since we've brought a large audience together with some of our grantees, and we're really pleased to reconnect with all of you. Beginning today and over the coming months, we will do a series of webinars highlighting work within each of our current major programs. Today's webinar will focus on the first program we launched in 2020, Access to Treatment for Vulnerable Populations. And specifically, we want to highlight this afternoon the significant data and policy contributions FORE grantees are making to help accelerate improvements in access to evidence-based treatment for opioid use disorder. You can go to the next slide. Thank you. And the next one. Great. So we have an abundance of rich information and dialogue for this afternoon. And following a brief introduction, we will hear about the Opioid E-QUAL Learning Collaborative, which is a focus on improving treatment of OUD and pain management in emergency departments across the country. We'll hear findings from analysis of Medicaid data about the characteristics of adolescent and young adult Medicaid enrollees with opioid use disorder and other substance use disorders. We'll hear analysis of the New Jersey Medicaid policy changes that were made in 2018, 2019 to improve access to buprenorphine and see what the impact of those policy changes have been. And we will hear more about analysis of how treatment initiation and changes and what treatment initiation and retention of buprenorphine has looked like during the pandemic. We will follow that with leaving a good amount of time at the end of the webinar for questions and answers. So please be thinking about and entering questions as we go through the presentations. So briefly to that point and on logistics, the webinar is being recorded and will be made available on our website shortly after the session ends. We will also make all the presentation slides available for download from our website. In terms of Q&A, please use the Q&A button that's found at the bottom of your Zoom screen. This allows us to do a couple things. We will track all the questions there, but also if you see a similar question already there, you can upvote it using the thumbs up button, and that will allow it to go to the top of the list. And again, as always, we'll try to get through as many questions as we can during the session. Please do not use chat for entering questions that you want us to try to get to. Please use the Q&A function. And finally, there'll be a brief survey at the end of the webinar. Please provide us with some feedback, thoughts on future topics, as well as what's helpful to you in your work. So a brief introduction to the foundation or an update for those of you who know us already. As many of you know, Foundation for Opioid Response Efforts is a fairly new private foundation launched late in 2018 to support and accelerate solutions to the opioid crisis. And I'm proud to say that to date, we've awarded 66 grants, committing over $30 million. And as a national foundation, we're building a network of grantees straight across the country, work that's going on locally at a county and state level in many parts of the country, as well as national projects. Next slide. Our programmatic areas continue to evolve and be informed by current events. But at the core, we continue to have an understanding that we will need a comprehensive approach to meet our goals of accelerating improvements. And so our projects have a patient-centered focus, and they span work on professional education, on payer and provider strategies, policy initiatives, and public awareness. The 4 specific major program areas where we've funded, launched our programs so far include access to treatment for vulnerable populations. Second program area where we funded projects to respond to what we were hearing as issues during the early months of the pandemic. That included supporting recovery services as well as launching a series of projects to evaluate the impact of some of the temporary regulatory changes brought about by the COVID public health emergency, such as more flexibilities for telehealth. And by the fall, we anticipate having some really very interesting findings from that work. We then launched a program called our Innovation Challenge to tackle some of the most intractable problems related to the opioid crisis, including stigma, as well as how to generate more timely and actionable data. And finally, just this March, we launched our first prevention-focused program, our family and community-based prevention for children, focused on children and families at highest risk. We also continue to develop our resources, and on our website, you will find issue briefs that help highlight the work of our grantees and what we are learning as the work develops, as well as links to our prior webinars and other materials and resources and products that are being developed directly by our grantees, such as our grantee Medicaid chart book developed by our team at Rutgers, who you'll hear from. And now to turn to today, the subject of today's programmatic focus on access to treatment. As a foundation, we determined very early on that access to evidence-based treatment for vulnerable populations would be our first major grant program, really for two simple reasons: the compelling evidence that MOUD, medications for opioid use disorder, save lives, and equally compelling evidence of the gap between those who could benefit from these medications and treatment and those who were receiving them. And this is one example illustrating that gap, data from Johns Hopkins analyses showing that just under 20% of those with a drug use disorder receiving any type of treatment in the prior year. We also heard from many stakeholders and advisors that there are many reasons for this gap. Barriers including stigma, having trained professionals, and financial and regulatory barriers. And so among the 20 projects that we're funding in the Access to Treatment program include projects that are developing new models of providing low barrier treatment, and others that are working to continue to increase our knowledge base and understanding of current levels of access, for whom, and how we can improve. And it's that last set of projects that we're really going to focus on today. And I'm now pleased to introduce and welcome our grantees and presenters for the afternoon. Dr. Arjun Venkatesh is Associate Professor and Chief of Section of Administration, Department of Emergency Medicine at Yale University. Victoria Lynch is Senior Research Associate at the Health Policy Center at the Urban Institute. Peter Treitler is Research Specialist at the Institute for Health, Healthcare Policy and Aging Research at Rutgers State University of New Jersey. And Dr. Brad Stein is Director of the Opioid Policy Tools and Information Center at the RAND Corporation. I'm very pleased now to turn it over to Arjun Venkatesh to launch the discussion and the presentations with a focus on the National E-QUAL Learning Collaborative. Arjun?
Thank you, Karen. Thank you all for joining today. Am I back?
Yes, good.
Thank you all for having me today. Thank you, Karen, for that great introduction. I'm excited to tell everybody about the Opioid E-QUAL Learning Collaborative today. We can go to the next slide. The collaborative, I serve as the principal investigator of the Emergency Quality Network, but really a lot of the credit goes to Dr. Catherine Hawk and Scott Weiner from Brigham and Women's, and Pete Hawk is at Yale with me, who have really been sort of the passion behind this work. They are national leaders in both emergency medicine, as well as addiction medicine and opioid use disorder, and the ACEP staff who help support this project, as we've really tried to do something innovative across the specialty with the support of the FORE Foundation. Next slide. Today we'll talk about our ACEP's E-QUAL network. I'd like to show some preliminary results from our 2021 Quality Improvement Initiative, and then a review of some of the educational products that have come out of this work as we have tried to sort of elevate the practice of emergency care to be more inclusive of treatment for opioid use disorder. Next slide. The E-QUAL network has a single mission: to engage emergency clinicians and leverage emergency departments to improve outcomes, coordinate care, and reduce costs. The network was started back in 2015 with support from the CMS Transforming Clinical Practice Initiative. We initially worked on areas such as sepsis, high-cost imaging, reducing hospitalizations, and found that we had developed a national learning network of EDs that were engaged in using QI for big problems. And so we turned that from those problems to opioid use disorder a few years ago. And the FORE Foundation support has really been instrumental in helping us make that transition and show that we can use sort of bread and butter QI approaches to reduce harm from opioids. We're currently enrolled 385 sites, 43 of which are critical access hospitals. And as you can see at the bottom there, nearly a third of the emergency departments participating in our network are in rural communities. What that means is that these are very small emergency departments, 16,000 visits a year, and on average, but representing almost 8,000 clinicians that work at these EDs around the country. And so we've tailored our content, how we think about practice, the types of tools that we support, and the best practices that we promote, not for the academic medical centers that I work at or others might work at that have tremendously different resources that they may be able to access, but for these average community EDs often, where sort of a single person is the medical director, the quality director, and the champion for work around opioid use disorder. Next slide. What do these EDs do? They join a national learning network, function really as a learning collaborative. Many of you have probably practiced in settings that have done this or are aware of these. And the model is fairly simple. It's built in ways off the IHI model for improvement. At the beginning, there's an enrollment questionnaire, and sites get a structural assessment of what type of resources they have to improve care around both sort of prevention efforts, such as naloxone distribution, as well as treatment efforts like buprenorphine initiation. There's then a 6 to 9 month learning period during which we provide educational content to these sites, but they're most importantly collecting and submitting and receiving rapid turnaround benchmarking data on key metrics around OUD care in the ED. And then at the end of the year, we provide a variety of what I call carrots to sort of ensure ongoing participation, recognize and acknowledge success, and really make sort of their participation in their work worthwhile. Next slide. The benchmarking activity is probably one of the core value propositions that the network has provided EDs around this country. ED sites identify visits based on diagnostic codes. Often these ED sites get support from their billing company or somebody else who can help them identify 30 charts. And then they do a manual review of those 30 charts. We give them data collection periods every year. We give just enough time for claims processing to occur on those data collection periods so that they have data they can look at. But then we get them a report, as you can see on the right side there, within 30 days on metrics that we can collect from that simple data collection. The type of metrics they see are of the ED visits they had for patients with opioid use disorder or an overdose, how many had a substance use evaluation in the ED? How many were given take-home naloxone where it was offered in the ED? How many had treatment administered in the ED? And this treatment really is methadone or buprenorphine. How many had treatment prescribed at discharge? What type of harm reduction practices were discussed and documented? And was there a referral for SUD treatment? Next slide. Here's some of the numbers. In the 2021 year, in the pre-wave period, there was about 5,000 roughly, and about 5,500 in the post-wave period of patients that were captured in this data collection. I think what's notable is that these are sites where this is being done by emergency physicians in small ED groups or part of larger groups that are staffing community EDs that were really facing the brunt of the Delta wave through some of this, and even sort of the tail end of a surge in 2020 from the COVID pandemic. And we were really sort of heartened to know that greater than 90% or so of our EDs did some sort of activity in the learning network through the COVID pandemic. What did we find? We found that over that sort of simple project that they implemented alongside other efforts in their ED, that there was a modest increase in the substance use evaluation rate. There was a decline in the offering of take-home naloxone. We think a lot of that has to do with changes that occurred, not just in the supply chain, but in how certain processes occurred within EDs during the pandemic. We probably most notably saw a 1% to 4% increase in OUD treatment administration. While on an absolute basis, that's fairly small, that's a fairly large relative increase that occurred in what is really a 4 to 5 month span that exists between these two data collection points. This isn't really year-to-year data. This is like a rapid change that happened in a couple months. by these sites implementing local protocols and initiating treatment. And similarly, we saw nice increases in referral to treatment as well. Next slide. When we looked at the data a little bit closer, what we saw was that when substance use evaluation was being offered, the pathway by which there was the biggest increase, where there was really EDs that were finding resources, it happened when they were developing community health worker or resource navigator type resources in their ED. It wasn't necessarily social workers, it wasn't necessarily psychiatrists or addiction medicine that changed. It was the ability to sort of identify these sort of folks that may or may not have lived experience, but really building off the relationships in the community to bring some of those resources to the emergency department as a focal point and a gateway to treatment. We also found that when we looked at whether or not substance use evaluation was occurring, where we saw the increase amongst our sites is that often this was already happening in overdose patients. It was the increase amongst non-overdose patients, patients who might have occult opioid use disorder or who may be identified as having opioid use disorder but not overdosed, where there was an increased number of referrals. Next slide. When we look at take-home naloxone, we saw that there was a decline overall, but interestingly, that decline was a decline in providing naloxone to non-overdose patients in the ED and an increase amongst overdose patients. And we think what this probably reflects is changing practices in departments when it comes to access to naloxone, probably fewer hospital level supplies to be able to hand out. And so people are focusing on what they perceive to be higher risk patients. Next slide. When we look at treatment in the ED, I alluded to this before, we saw an increase in treatment overall, and that occurred both in rural and non-rural settings. And we were really sort of pleasantly surprised to see this because launching a new treatment program requires a lot, it really requires turning the ship in the emergency department. And these EDs did it at a time while they were really juggling a lot of change in the COVID pandemic. This was around the time of vaccination launches. This is around the times of a lot of testing changes in many communities. This is around the time of some treatment changes. And so for them to make a treatment change on something that was sort of, we know, much worse in the setting of the pandemic, but not directly in the lens of the pandemic, was reassuring because we thought that a lot of sites would probably head the other direction, go backwards with all priorities and resources directed at COVID. Next slide. When we look at treatment prescribed at discharge, here what you see is that there was a small increase in people that were getting buprenorphine or methadone at discharge. That was a sort of both primarily amongst the overdose patient, not amongst the non-overdose patient. What's interesting here is that you have an overall increase with what looks like a big decrease in non-overdose patients. And so what was really happening was, I think, a little bit of a shift in practice, which is probably favorable, which has been that there's a historical teaching, that if a patient just had an overdose, there's too much of a risk of precipitated withdrawal or something else if you give them treatment in the emergency department. But a lot of the educational tools we have been putting together and a lot of the things the materials we've been putting together has been favoring early treatment and using overdose as a motivation for treatment. And I think that you're starting to see some of that change in practice emergency medicine nationally when you look at these numbers. Next slide. This was around whether or not there was documentation around harm reduction efforts. There was not really much movement on this slide. It's, again, not the best measure that we have, but it's what's sort of available. And so we sort of saw that, about 2/3 of the time this was happening. Next slide. We've collected some qualitative data through the network, and we asked people about what barriers they faced in sort of initiating or sustaining treatment programs out of their ED. It was very focused on treatment for OUD. And what we thought was interesting is a few things. The first, there's a word that is missing in this world cloud for data collected in 2021, which is COVID, and I was shocked to see that. And so that was a pleasant surprise. The second thing is that look at the top bullet. I am thrilled that that was actually the top bullet and that we're having this discussion today coming off the Senate vote on the MAT Act, where limited clinician access because of X waivers and that being one impediment to broader prescribing was consistently brought up from a variety of sites. And hopefully with this new legislation, the recent notice of intent relaxation, we will see more and more people find it easier and easier to prescribe. It will not be alone sufficient to sort of broaden ED prescribing, but it will certainly is a necessary barrier to remove. And then you see a few other there that I think are probably no surprise to this audience and crowd of the types of things EDs face when they find themselves challenged with initiating these programs. Next slide. We've tried to disseminate this work widely. You know, in the world of emergency medicine, we're slowly getting back towards some in-person meetings. Some of them have been virtual, but we've presented these analyses at the American College of Emergency Physicians, the Society for Academic Emergency Medicine. We are presenting at AMERISA this year. With the FORE Foundation support, we presented at the Overdose Prevention Leadership Summit, and then at the ED Benchmarking Alliance as well. And so we're trying to make this data about treatment for OUD widely recognized. We're not actually going to some of the traditional outlets you would imagine in the substance use disorder world. Where we're trying to go is the world of clinical emergency physicians or ED operations. We're really trying to make care for opioid use disorder in the ED not sort of a special add-on program, but just part of regular everyday operations, just like we've got treatment for acute myocardial infarction, for CHF, that we sort of put front and center in regular ED operations. Our vision is that if we can normalize these programs to that level, that will be our biggest sort of victory with this type of work. Next slide. So I'll stop there. I have the staff up there. I thank everybody for this chance. I'll be back for questions. And then there's the contact info there in the slides if you're interested in joining. But with that, I'll turn it over to Victoria.
Good afternoon, everybody. It's a pleasure to have the opportunity to present our findings on the prevalence and characteristics of adolescent and young adult Medicaid enrollees with OUD and other substance use disorders. First, I want to thank FORE for this opportunity and also point to my colleague and the PI in this project, Lisa Clemens-Cope, and thank our research assistant, Maya Payton. Next slide, please. I'm going to try to breeze through these early slides because there's a lot on the findings that may be more new to y'all. So first, we're studying adolescent and young adults because these are key periods in the development of OUD and other SUDs. We note the large body of health services literature showing that health services can prevent, identify, treat, and reduce the harms from SUD, and that it's known that a large percentage of adolescents and young adults get health services through state Medicaid programs. Thus, it's important for state Medicaid officials and other policy makers to know more about the demographic and health-related characteristics of this population in order to better identify and strategically close gaps in the recommended receipt of recommended SUD-related services. Next slide, please. So the data we used was the TMSIS. We had samples from 5 states from 2018. Our data cover enrollment in all Medicaid paid services. We note that the TMSIS is relatively new, so there's still some uncertainty about the validity of elements for studying SUD and other research more broadly. Our study sample focused on age group, adolescents defined as age 12 to 18 and young adults defined as age 19 to 25 years. Type of SUD, which was OUD, and then other SUD, which was alcohol, psychostimulants, marijuana, cocaine, other specified and other unspecified use disorders. Our sample sizes, you can see in this little table, were pretty substantial, less so in DC. This is people identified with an SUD. So for the adolescents was quite a bit smaller, and for some of our analyses, we combined them. Next slide, please. So the research questions we were motivated by, first, were the data valid in different states for measuring OUD, other SUD related services and key demographic and health related characteristics? What's the prevalence? What are the characteristics of enrollees identified? And what percentage of adolescent and young adult enrollees with OUD have claims for medication treatment for OUD ever in the year? What type of MOUD do we observe, and how many months did they use it? So real quickly, our methods, we use our behavioral health service algorithm to identify OUD and other SUD diagnoses, MOUD, other treatment related services. We also identified mental health conditions, pregnancy, recent childbirth, demographic health characteristics. We addressed missing race and ethnicity data. And finally, we produced descriptive statistics, some of which I'll show you in the coming slides. So first, on the validity of TMSIS for OUD-related research, we found it to be generally valid, and I'd be happy to circle back and say more, but the exception was missing race and ethnicity data in some states, which is pretty well documented. For our, in this particular study, we were missing about half of the enrollees in Massachusetts, race ethnicity for those folks, and about close to 20% in Washington, DC. It was much lower in other states, ranging from 0.5% among adolescents in New Mexico to 6% among young adults in California. We did as part of our work, we did some exploratory edits and imputations, which make a small difference, but still leave us with meaningful missingness. Next slide, please. So the findings on prevalence, it's very low among adolescent enrollees. In Colorado, we observed the highest prevalence, which at just 0.13% of that, the Medicaid population. And it was higher among young adults, ranging from 0.2% in DC to 2.8% in New Mexico. We observed a fair bit of co-occurring SUD, not surprisingly, and I'll tell you more about that in other slides. So other SUD was substantially higher than just OUD, any OUD, and that ranged from 1.2% in California to 2.5% in New Mexico among adolescents. And then for young adults, it ranged from 3% in California to 5.7% in New Mexico. The most common ones, as you can suspect, is marijuana, alcohol, amphetamines. Next slide, please. So the characteristics, I'll slow down a bit here. Here we see marijuana use disorder by age group and OUD, SUD status. So you can see on the left that close to 1 in 3 adolescents with OUD also had a marijuana use disorder identified. And then the turquoise among shows that about 2/3 of the adolescents we identified with another SUD had marijuana use disorder. And keeping in mind there's other co-occurring SUDs observed for these folks. For the young adults, you can see that marijuana use disorder was less than the adolescents with SUDs. Next slide, please. This slide shows any mental health condition by age group and OUD, SUD status. And I'll get into the specific conditions we looked at in a couple of slides. But here you can see on the left that we identified a higher percentage of adolescents with with SUDs having a mental health condition also identified. It's basically 79% of the adolescents with OUD had another mental health condition, and also 61% among the adolescents with other SUD. It's lower, but still substantial among young adults with SUD. And as you can see from the black bars, those are the adolescents and young adults with no SUD identified. We see much less mental health conditions identified. This slide shows disability by age group and OUD, SUD status. So you can see from the short bars that disability was not identified among very many people, but there are important differences here. You can see on the left side among the adolescents, 15% of those identified with OUD also had a disability identified, which is substantially more than among the adolescents with no SUD and even the adolescents with another SUD. Next slide, please. So here you can see the types of co-occurring mental health conditions. And I know that there's a lot of bars here, but note that on the left, it's higher for each one of them, and the left are the adolescents. You can see all the way to the left in the dark blue, suicidality was identified in almost a quarter of the adolescents with OUD, compared to about 10% of young adults with OUD over on the right. Depression and anxiety, the turquoise and black bars were not surprisingly also quite high. You can see the yellow that about a quarter of the adolescents with OUD were identified as having PTSD, compared to about 11 or 12% of the young adults with OUD. Conduct disorder was also high. Okay, no, you could go to the next slide. Next slide here, yeah. So this one shows similar levels of medication for OUD, but different types of MOUD across the youth age groups. So the dark blue shows any MOUD. So you can see close to a third, 1 in 3 of adolescents and young adults had MOUD ever in the year. But you can see from the next bars that it varied by type. So adolescents, not surprisingly, we don't really see much methadone, as compared to young adults, 22.5% of those identified with OUD had methadone during the year. Also variation in buprenorphine, we see 5.7% among across the 5-state sample for adolescents, compared to 25% of the young adults. And then naltrexone is pretty different. You can see that 27.6% in the gray of the adolescents had naltrexone at some point in the year, compared to close to 10% of the young adults with OUD. This slide, you can see similar numbers of months of the year with MOUD, but a fairly low percentage. So the dark blue, you can see that 19% of the adolescents and basically 19% of the young adults had MOUD 1 to 3 months of the year. And those are not necessarily continuous, although we do look at that too. And 6.5% had 7+ months, and 8% of the young adults had 7+ months. So in general, it's not a long time. This slide shows any office medical visit in the year. So the big takeaway here is just that people are getting medical services in an office, and particularly those with SUD. It's basically 4 out of 5 of the adolescents with OUD were observed in an office setting, and it's higher among folks with an SUD diagnosis. Similarly, you can see here any emergency department visit in the year. More than half of the adolescents and young adults with an SUD were observed at least once in the ED, and substantially more than among the adolescents and young adults with no SUD. Similarly, we see here the inpatient hospital stays in the year. This does not include psych, and it does include pregnancies, which makes it a little bit harder to infer, or sorry, birth. But basically, you can see that among the adolescents with OUD and the young adults with an SUD, roughly 1 in 3 had an inpatient stay. Next slide. This slide shows pregnancy and recent childbirth by age group and OUD SUD status. So you can see the bars are pretty small. It's not that common, but it's quite a bit higher among people with SUD. So looking on the left side at adolescent girls, 6.5% of those with OUD and 8.5% with another SUD were also identified as being pregnant or having recent childbirth in the year, compared to about 1% of other adolescent girls. And on the young adult side, it's also higher among those who have an SUD identified. So in this slide, I just give some examples of the state variation that we saw among young adults. The young adults we were able to compare across states, and we noted important geographic and race ethnicity differences. So for example, in California, we saw disproportionate OUD in rural counties. By contrast, in New Mexico, we see disproportionate OUD in urban counties. In Colorado, we didn't see a pattern. no meaningful variation across the counties. And then in Massachusetts, we saw disproportionate OUD in some urban counties and some rural counties. Oh, let me just say the race ethnicity. So race ethnicity also had different patterns. In Hispanic young adults were disproportionately high percentage of those with OUD in New Mexico. By contrast, in California, they were disproportionately low percentage of those with OUD. Similar pattern with American Indian, Alaska Native young adults, where they were disproportionately low percentage of those with OUD in New Mexico, but a disproportionately high percentage in California. And same thing with white young adults, very disproportionate high percentage with OUD and other SUD in California, but not disproportionate in New Mexico. Next slide. Okay, so I'm gonna have to hurry up here. Real quick, this just shows MOUD by state. We see a little bit of variation, especially New Mexico stands out as having higher MOUD. Next slide. So discussion, some things we want to point out, that the valid TMSIS data for SUD research really points to tremendous opportunity to look at local geographies, small populations with this large data set. We note that while we don't see, there's low prevalence in the Medicaid population. These are people with urgent health issues, particularly around suicide and mental health issues. Also just note that there's contact with medical providers, but nevertheless substantial gaps in MOUD. Next slide. We note again the questions around the pregnancy and birth and the pointing to the issues with access to contraception and sexual violence and the need to further explore the possibility or the role that pregnancy and the birth experience may have in people reporting care, reporting substance use, seeking care, or provider screening. Next slide. This basically says we have a lot of ideas for further research. We'd really like to look more at social determinants of health and look at the policy changes, particularly in places like Virginia and the impact that it had, and to look more closely at small and disadvantaged populations. And I think I need to turn it to the next person. Next up is Peter Treitler. Thanks, everybody.
Thanks, Victoria, and also thank you to the FORE Foundation for this opportunity to present. So our project focuses on payer and provider strategies for expanding access to MOUD in primary care and other settings. And so I'm going to talk about a study we did on the association of 2019 New Jersey policies with buprenorphine prescribing and utilization. And then I'll also share some results from qualitative interviews we did to better understand provider and stakeholder perspectives on policy impacts and remaining things that need to be addressed through policy and practice changes. Next slide. And so this is just an overview of the Medicaid policies that we've been focused on, which were all implemented around the same time in 2019. And first you have the MAT-RX model, which you can think of essentially as a provider network, sort of like a hub and spoke model, where you have 2 regional centers of excellence in the northern and southern regions of New Jersey. These are based out of large academic medical centers and they're well resourced. Then you have kind of in the middle, the premier providers, which are integrated care settings. And these include CCBHCs, FQHCs, and some SUD specialty treatment clinics. And then you have a growing and relatively large network of office-based addiction treatment providers. And then another major policy change was the elimination of prior authorizations. Next slide. And so just to say a little bit more about the OBAT. So the OBAT model was actually a specific program in New Jersey implemented by Medicaid, which enhanced reimbursement for MAT services in office-based settings. It brought the reimbursement rates up to or above Medicare rates, which is a considerable increase from the typical rates. But it also required, so providers had to enroll in this program, and a requirement was that they offer patient navigation services within their clinic to help patients meet their psychosocial needs. But those patient navigation services were also reimbursable fully by Medicaid. The second policy change was elimination of prior authorizations for medications for addiction treatment for OUD and alcohol use disorder. And so the initial policy said that prior authorizations were not allowed for any forms, FDA-approved forms of medications. But safety edits were still permitted and formulary, restrictions. So that was then updated later to require managed care organizations to cover all generic buprenorphine up to 32 milligrams a day. And third, the Medicaid office established the 2 regional centers of excellence, which in addition to treating thousands of patients themselves across the 2 sites, they also provide training, consultation, and technical assistance to MAT providers, and also help with disseminating best practices and launching programs like office-based practices. Next slide. And so just a bit of an overview of the methodology for the work we're talking about today. For the quantitative side of things, we used interrupted time series analyses to look at the association of the Medicaid policies with prescribing and utilization trends. And then on the qualitative side, we did interviews with 22 New Jersey office-based providers and also 8 stakeholder key informants, which included policymakers, managed care organizations, and advocates. Next slide. And so starting with the quantitative research, these are the outcomes we looked at in our trend analyses. We were seeing if the policies were associated with a change in the number of buprenorphine prescribers overall and by specialty. And then at the patient level, we were looking at whether the policies were associated with a change in buprenorphine utilization among the Medicaid population with opioid use disorder. And then as a measure of retention, we were looking at the percentage of episodes that lasted for 30 or more days. Next slide. Keep going. So yeah, starting with the provider level findings, it's a busy slide, but there's some information there in case you want to look at these after the presentation. But essentially, if you focus on the figure to the left, the solid line shows the trend before the policies were implemented, and then the gray shaded area is the post-policy period, with the dotted line showing the pre-existing pre-policy trend if that were to continue. And then the dashed line is the actual observed post-policy trend. And the green dots are the actual observed values. So for this chart, it's showing the number of buprenorphine prescribers. So the number of physicians or other prescribers who whose patients filled at least 1 buprenorphine prescription in the month. And that's per 1,000 overall prescribers in Medicaid. So the denominator is Medicaid prescribers who had at least 1 prescription of any kind in the month. And so you can see here that the number of prescribers was increasing before the policy, but then there was an association of the policy with both an immediate increase and then a trend change. So the number of prescribers increases more quickly after the policies go into effect in April 2019. Next slide. And then in these next 2 slides, we break it out by specialties. And so first you have primary care, psychiatry, and emergency medicine. And the trends overall are pretty similar. Interestingly, with primary care, there was actually a decreasing proportion of primary care prescribers were prescribing buprenorphine in the pre-policy period, but then there's a pretty marked shift there in the post-policy period where the trend is actually increasing. And emergency medicine, interestingly, thinking about Arjun's presentation, there was a huge increase there. Early on, before the policies were implemented, a relatively small number of prescribers, emergency medicine prescribers were doing buprenorphine, but there's a large increase after the policy goes into effect. Next slide. And similarly for other physicians with other specialties, there's also an increase, although the magnitude is smaller. And lastly, mid-level practitioners, nurse practitioners, and physician's assistants, there's also an increase associated with the policies. And then this slide is really just showing the percentage of all buprenorphine prescribers who are nurse practitioners or physician's assistants. And you'll see there's a 3rd policy period modeled there, or rather a 3rd trend modeled there early on. And that's because mid-level practitioners couldn't prescribe buprenorphine until I think it was mid-2016. But then starting in 2017, you see a pretty rapid increase in the proportion of buprenorphine prescribers who are mid-level practitioners. And that trend doesn't change when the policies go into effect. It kind of just continues at the same rate. But by the end of the study period, by the end of 2020, I think around 27% of buprenorphine prescribers in any given in the month were mid-level practitioners. So moving on to the patient level findings, next slide. This shows the trends in the number of Medicaid enrollees with opioid use disorder who are receiving buprenorphine in any given month. And so the denominator here was Medicaid enrollees who had an OUD diagnosis in the prior 6 months. And the trends are pretty similar to what we saw in the provider analyses, where there was an increase in the pre-policy period, but then there was an association of the policy with a change in the trend where the increase happened faster. Next slide. And then as a measure of retention, we also looked at the percentage of new buprenorphine episodes in each of these months that was lasting 30 or more days. And we used 30 days instead of the standard 180 days because we didn't have enough of a follow-up period to track that measure for a long enough period of time. But as you can see, that there was actually a declining trend in retention. Before the policies went into effect, it was declining at a relatively low rate. But then after the policies went into effect, that rate accelerated. I do want to note that the actual number of episodes lasting 30 or more days increased over the study period. So it actually looks like the previous slide. It's just that the actual percentage of new episodes that lasted 30 or more days was decreasing. And so we have some thoughts about why that might be, but that's something we'll hold off for the discussion. So next slide. Okay, so I'm switching gears now to some of the qualitative work that we've done. And again, this is from interviews with 22 buprenorphine prescribers in New Jersey, and then 8 policy stakeholders, which included policymakers, managed care organizations, and advocates. The first kind of topic area was related to implementation of the office-based addiction treatment program. That's the Medicaid reimbursement program. And so some of the themes are listed on the side here, but we asked providers, why did you enroll in the program? And not surprisingly, it had a lot to do with the financial incentives, which was much higher reimbursement. But providers also talked about how having the reimbursement for patient navigation was attractive because it would help them to address all those non-medical needs that OUD patients tend to have. Who enrolled was interesting because the program was largely designed for primary care providers. The idea was that this would attract primary care providers who happen to be seeing patients with opioid use disorder in their clinics, and that this would give them a mechanism to treat those patients so they wouldn't have to go to some other setting for their care. But what actually happened in practice, even though a good number of PCPs did sign up, other specialties also enrolled in larger numbers than expected. And one group that was pretty common was physician aggregators, which are sort of these larger, sometimes multi-state organizations that hire physicians to do the MOUD piece. And then the physician aggregator organization takes care of the back end, including the navigation and billing and that kind of thing. But overall, it did result in an increase in the number of providers, as we can see in the prior slides. We also asked about enrollment barriers because the enrollment, although a good number of providers did enroll, it wasn't nearly as many, obviously, as there are practitioners in New Jersey, not even close. So we asked what were some of the barriers, and one was a lack of program awareness. Even though it did increase rates for services, there was no startup funding, which some thought to be a challenge. The requirement for patient navigation was one that came up several times. So even though patient navigation was reimbursed, some providers were concerned that they wouldn't be able to keep that person, occupied if they hired a new person to be patient navigator, or they were concerned if they used existing staff like medical assistant or nurse, that it would take away from the time they had to complete their other tasks. Another issue was some providers just thought that the medical and psychosocial needs of patients with opioid use disorder, particularly those in Medicaid, were too great that they didn't really want to provide services in an office-based setting. And then the last thing we asked about was just kind of everybody's perceptions on the patient navigation component. And overall, people spoke favorably about it and described how it helped improve care. It gave the organization more touch points with patients. And then, of course, it also helped patients get connected to other needs like housing and transportation. Next slide. So in these interviews, we also just asked stakeholders and providers more generally, how has care improved in New Jersey as a result of these policies and other changes? And what other recommendations do they have for further changes? And so one of the themes that came up several times was medication approvals. And everybody spoke very highly about the elimination of prior authorizations as being extremely helpful. But there were still some barriers, especially when it came to Sublocade. Even though there are no prior authorizations for it, the process of obtaining Sublocade is quite burdensome, so most practices are not offering it. The need for psychosocial support was also highlighted, so psychiatry and mental health care in New Jersey for Medicaid beneficiaries is very limited. We also found that there's relatively low integration between OBATs and the many recovery support resources available in New Jersey. So New Jersey has invested a lot in expanding recovery support in the state, but we didn't hear much about those being connected to the office-based clinics. There was also the stigma issue came up quite a bit, which not only kept providers from enrolling in OBAT, but it also impacted the way that they treat patients. So just in the 22 providers we spoke to, there was substantial variations in how they practiced MOUD, when it came to dosage, the length of treatment and expectations around tapering. And so we just found that, and stigma seemed to impact that, their perspectives on those things. And lastly, a number of people recommended expanding MOUD into other settings, such as EDs, prisons and jails, and OBGYN offices. Next slide. So some of the takeaways from the research, our findings suggest that the New Jersey policies reduced barriers to buprenorphine prescribing and increased access to MOUD. Overall, buprenorphine prescribing remains relatively low across the specialty. It's about 2.7% in a given month. So there's, of course, a lot of room for improvement. The growth in mid-level practitioners treating prescribing buprenorphine has helped to address the gap. And importantly, the retention remains a major challenge. So it's important to consider potential strategies to improve that. Next slide. And then some other lessons learned and policy opportunities, mainly from the interviews. Working out improved processes for obtaining Sublocade so that it's more of an option for patients who could benefit from it. Continuing education through the COEs or other organizations to address stigma and also promote evidence-based kind of uniform care. Incentives for prescribing in integrated care settings and non-traditional settings where medications remain underprescribed. And then exploring the pharmacy level barriers and potential solutions. And then specifically for the OBAT program, some potential changes structurally there, or for other states that might be looking to implement a similar benefit. Maybe considering an alternate structure for patient navigation. For example, one respondent we spoke to suggested having the state handle the patient navigation so that the providers wouldn't have to hire their own. Also efforts to raise awareness for the program, ensuring the enrollment and billing processes are clear, and finally, better integrating coordination with recovery support and psychosocial service providers. All right, so I'll end there and turn it over to Bradley Stein. Thank you.
Peter, thank you very much. And I'm pleased to be here this afternoon. Ken, I think you need to start my video, but I will just sort of dive right in as we're going. So following three great talks, what I'm going to do during this last talk is sort of zoom out a little bit. And really, we're going to look at national data, but focusing on what happened during the first year of the pandemic. Next slide, please. And we're going to be focusing on opioid use disorder. I have the pleasure of sharing what we've learned with you this afternoon. But this work can't be done without a number of great colleagues, and certainly need to thank the FORE Foundation both for supporting this work and for giving me an opportunity to share it with you this afternoon. Next slide, please. So usually I have a slide here talking about how the opioid crisis has continued to worsen. I figured being the fourth talk, someone would have done it before, and I was a little bit surprised that no one has, but I don't think it's a surprise to this audience how much the opioid crisis has continued to worsen during COVID. The fatal overdose rate, numbers of fatal overdoses are the highest they've ever been. But I think it's important to recognize the larger context that it goes beyond fatal overdoses. Opioid use disorder and polysubstance use crisis continues to worsen. It's not just opioids. And it really takes place within the context of some of the greater impacts that COVID has had on our society. Certainly many of us during COVID, and particularly during the first year, experienced much greater psychological stress and distress. There was greater isolation. There was much greater anxiety. And as a result, not surprisingly, in addition to sort of worse metrics when we're talking about opioids during COVID, is we saw higher rates of mental health disorders more generally, higher rates of all types of substance use, alcohol and other drug use and misuse, and a significant increase in substance use disorders. So as we're thinking about buprenorphine treatment for opioid use disorder during COVID and what may have happened, I think it's important to remind ourselves of this context. Similarly, during that period, there are substantial disruptions in the delivery of healthcare in the United States. Early on, there was a greater than 50% decline in outpatient physical healthcare. However, since then, we've seen physical healthcare utilization is returning much closer to the pre-pandemic baseline. If we look at behavioral healthcare during COVID, in general, I think we saw less decline in terms of behavioral healthcare overall. And I think a lot of people attribute this to substantial adoption of telehealth that had greater penetration within the treatment of behavioral health disorders. Than could occur in some cases for physical health disorders, where in many cases you actually needed the patient in your office. I think as we sort of look around now, we see that telehealth use is dropping, but that it's doing so less so in behavioral health. It tends to be a bit stickier. And so, as we're thinking about what happened during the first year of COVID, there's a larger context in which we're talking. Next slide, please. So, one of the reasons why we feel there was less decline in behavioral health services and treatment for substance use disorder and opioid use disorder is that policymakers really stepped up, and there are a whole variety of changes related to treatment of opioid use disorder and substance use disorder during COVID. So when I talk to people, the first response people come up with is telehealth. Right, that's often what we hear is people talking about telehealth. And certainly we saw relaxation of telehealth policies overall in many states, but also buprenorphine specific, specifically being able to initiate buprenorphine treatment via telehealth. But I also think it's important to recognize that there were a whole variety of other policy changes that really could serve to support treatment of substance use disorder and opioid use disorder. Relaxed policies allowing out-of-state clinicians in different states to provide treatment for individuals. And obviously this was particularly important in the context of telehealth, but also the granting of temporary licenses. And there are a whole variety of substance use disorder policy changes. Changes in relaxing prior authorization requirements, waiving of copayments, less drug screening, a whole variety of things that may affect the treatment of substance use disorder. And again, I think I'm not going to go into them today, but again, as we take the kind of a wider view, there are also changes in terms of Medicaid enrollment and eligibility, trying to ensure people didn't lose insurance and were able to stay on Medicaid rolls, and also relaxation of methadone policies, which for some individuals may affect their need or willingness to be able to receive buprenorphine. Next slide, please. So in the context of both the changing environment related to opioids in the light of COVID, in the context of all those health system and policy changes, we wanted to sort of understand what was going on with buprenorphine treatment. So the backdrop of what we were doing here is many studies have looked at sort of top rate numbers of buprenorphine treatment, prescriptions or overall individuals. And I think in general, the feeling is compared to many other types of treatment during the first year of COVID, where you saw significant declines, buprenorphine seemed to stay relatively stable. But we wanted to sort of dig into that story and understand if there was a bit more by understanding the dynamics of the buprenorphine treatment episodes and how they may have changed from the pre-pandemic. So in addition to sort of looking at the total number of active buprenorphine treatment episodes, and I'll describe what those are in a moment, we also want to look at the number of people who were starting treatment and the number of people who were in treatment who ended their treatment episode, really trying to understand if there was more going on here than just a relatively flat rate of buprenorphine staying stable. Next slide, please. So what did we do? We used 2019 and 2020 pharmacy claims from IQVIA, which during this period captured about 92% of prescriptions filled in retail pharmacies. And we created active buprenorphine treatment episodes and essentially looked at what happened in the period before COVID and in the comparable period during COVID. And as I said, we were looking at sort of the total number of active treatment episodes, then the number of treatment episodes that started during those periods, and the number of treatment episodes that ended during those periods. Next slide, please. So what was a buprenorphine treatment episode? People have approached this a little bit differently, but what we did is kind of pretty common in the field. What we did is we picked up the first observed dispensed buprenorphine prescription for buprenorphine formulations indicated for the treatment of opioid use disorder. So we excluded buprenorphine indicated primarily for the treatment of pain. And we essentially followed those episodes in days supply until an individual ran out and there was an additional 30 days where they didn't fill a prescription. And so we were also sort of curious as to how what we were looking at may have evolved over the course of COVID. So we looked in both years, 2019 and 2020, from March 13th to December 1st. So in 2020, that's basically with the declaration of the public health emergency. And we looked for the rest of the year, leaving enough time to allow us to see episodes ending. We looked at the comparable period in 2019. And then we split it into 3 periods to see if sort of there were shifts in what was going over time. So we broke it into what I'll call spring, summer, and fall, approximately 2-month periods each. Next slide, please. So what we did is we calculated active episodes, new episodes, and episodes ending in 2019 and in 2020 overall, and by each of those period. And then for those, we also looked some at kind of payer, prescriber, and county characteristics of those overall episodes. Then what we did is we estimated an expected number of episodes of what we thought we would see in 2020. And I'm sure there are far more sophisticated ways to do this, but basically we said, okay, let's look at the pattern in 2019 and see what happened during the year and assume we'd sort of see the same pattern in 2020. Then we started at March 13th and said, okay, what did we actually see? And the discrepancy between what we actually saw and what we thought we'd see based on the same pattern in 2019 is what I'll refer to as expected episodes. So what did we learn? Next slide, please. So in 2020, compared to 2019, there was about an 8% increase in active buprenorphine episodes. Now, modest increase. When we looked at the pattern of growth that we saw in 2019, it actually turns out that this is 2.5% fewer active buprenorphine episodes than we thought we'd see. So I think this is pretty consistent with the prior literature. And it, that's pretty flat in terms of what we would see, certainly not the same types of declines we saw in other types of healthcare. Next slide, please. However, when we started to look at some of the characteristics of the episodes, we did see some important variation here. When we looked at payer and just the number of active episodes, we actually saw that compared to the 8.5% increase overall, that there was a 13% increase in episodes paid for by Medicaid in 2020 compared to 2019. And the number of episodes that were self-pay actually was the increase was lower. So sort of functionally that number went down. We also saw, and I think this is no surprise, and we've seen a similar slide in the last talk, we saw a tremendous increase in the number of episodes where the primary prescriber was an advanced practice provider, a physician's assistant or a nurse practitioner. In terms of episodes from emergency physicians, that was about flat. And actually episodes from most of the other types of prescribers were slightly less than the 8.5%. Then finally, when we looked at what were the county characteristics of where we saw sort of the greatest increase in 2020 compared to 2019, there were some variation here, and some of which we found a little bit surprising. One thing we found, which was not surprising, but certainly concerning, is the greatest increases were in those counties that were above. So we broke counties into quartiles, okay? And the greatest increase were in those counties that were above the median in their percentage of white residents. So essentially they were the whitest counties had the greatest increase. We also saw a greater increase in 2020 in the quartile of counties that had the lowest fatal overdose rate in 2019. So if we consider the fatal overdose rate sort of a proxy for need for treatment, these were the counties where the opioid overdose rate, or at least the overdose rate, was lowest, which is a little concerning. The other thing that we found somewhat surprising is that the greatest increase in terms of counties with respect to episodes was in the counties that had the lowest broadband penetration. So one of the things we think about in telehealth is people being able to sort of access and use telehealth services. And so we were a little surprised in those counties where it seemed telehealth services and the broadband to support them was least present, were those counties that had the greatest increase in episodes. So now let me turn from county characteristics and let's look at sort of episode starting and episode ending. Next slide, please. All right, so as we look at people starting treatment, we actually saw that there was a substantial decrease, almost 50,000 fewer new treatment episodes during 2020 than 2019 in that March to December period. When you put this in terms of what we would have expected to see if we had seen the same pattern as we saw in 2019, this was a 17%, there were 17% fewer new episodes than we would have otherwise expected. And when we looked at this across periods, there was some variation, but it wasn't that this was all accrued right after COVID started. While the greatest decrease in new episodes was sort of in that March to June period, we saw substantial decreases in new episodes in the other two time periods also. Next slide, please. Now, if you can do the math, if overall episodes stayed about the same, the only way you get to sort of the same number of episodes if there are fewer new episodes is we also saw a substantial decrease in the number of people and the number of treatment episodes ending. There were 40,000 fewer people ending treatment episodes in 2020 than 2019. So essentially the number of treatment episodes ending was 16% less than it would have been expected it was 16% less in 2020 than we would have expected using this 2019 numbers. Again, somewhat of a surprise. And again, when we look at kind of how it broke out by time period, it's the same pattern as we saw for the new episodes. The greatest decrease was in that spring period. Next slide, please. So I want to be respectful of time. I know we have conversation after this, so let me try to wrap up pretty quickly. While overall buprenorphine seemed relatively stable during 2020, and this is probably good news given all the concerns we have about the opioid crisis and the pandemic. That's probably good news. Although the one point I want to make before I move on from this slide is, given all of those factors and all the stresses caused by the pandemic, is stable really what we should have been seeing, or should we have expected actually there to be more episodes given what we believe was likely greater need in the population? Next slide. In terms of fewer episodes ending, a 16% decrease is actually shocking, right? That's a dramatic decrease in a 1 year of people leaving treatment. Why? You know, we talked to a bunch of people and get a whole bunch of different answers, and I think there's a whole variety of important questions we need to continue to dig into. We talked about all those relaxed regulations around buprenorphine and SUD treatment more generally, and telehealth. All of those things probably make it easier for people to stay in treatment. We had enhanced Medicaid coverage, and we certainly saw more Medicaid episodes. Also, as people were staying at home often, or didn't have many of the commitments they had had prior to the pandemic and were less able to travel, it may have also been easier for them to be able to attend some of these appointments than they had previously. And this may have contributed to staying in treatment. Another explanation somewhat offered is clinicians being concerned about their own income may have been less likely to discharge patients. So there are a whole variety of possibilities here. You know, I think the takeaway is, in general, we think longer buprenorphine treatment is desirable. So understanding the factors that contribute to people staying in treatment may be important, for us to learn from what happened during the pandemic and think about to what extent may we be able to support those things going forward. And as you see here, there are a variety of possible explanations that I think we need to understand better. Next slide, please. We also saw far fewer people starting treatment. And this, I think, was equally shocking. Why? Well, you know, I've at least had a couple people argue that, you know, maybe fewer individuals were seeking treatment for some reason. I personally find that unlikely, given what we know about COVID and drug use and the other stressors, but I did want to offer it. Similarly, individuals may have lost commercial insurance coverage as another sort of explanation I've been offered. And we certainly know that that happened during the pandemic or during the first year of COVID. But Medicaid should have mitigated this to some extent. So again, I'm not sure I find that a completely satisfying solution, although it could have contributed to it. One other possibility, and I think one that we need to understand more, is if you think about the dynamic here, and I'm talking about dynamics, if we have fewer people leaving treatment, and for whatever reason, clinicians have sort of a certain number of treatment slots they have for buprenorphine patients, if you have fewer people leaving, then there are fewer slots for people to start treatment. And if that's the case, this sort of comes to a supply constraint that many of us have talked about previously, and I'm sure many of you out there have thought about, that is something that we still need to figure out how to address better. But bottom line, assuming that demand for treatment did increase, the substantial decrease in new episodes that we saw is concerning, because it really suggests that there are people out there that needed treatment that may not have been able to get it. Next slide. Briefly, payer and county characteristics. I've talked a little bit about this, understanding what happens with I'm actually going to move past this slide because I've sort of touched on these previously. Next slide. I'm happy to come back to this in the questions. Bottom line, some thoughts I'd like folks to leave here with. Number of buprenorphine episodes stayed stable during the first year of COVID. You know, compared to the other healthcare, we think about that as probably being a success. But given the larger context, I think we need to really consider, is that sort of a glass half full or half empty? Is that really what we should have been aspiring to and wanting to see? Fewer episodes ending? probably good news if it means people are staying in treatment longer, considering we believe longer treatment duration is associated with better outcomes. However, fewer patients starting treatment, bad news if it means people that need treatment aren't getting into it. So unfortunately, I don't have the policy recommendations here that many of the prior panelists had, but hopefully I've given you something to think about going forward. Thank you very much.
Brad, thank you so much, and thank you to all of our panelists for really fascinating information and provocative data for us to be continuing to think about and discuss. We do have a few minutes for questions, and we also are joined by Professor Stephen Crystal. There he is. Also leading the Health Policy Center at Rutgers University and PI on the project presented by Peter. I think we have all of our presenters on now. I want to thank all of our audience for lots of great interaction, questions, and comments in the Q&A. I want to thank our presenters who have been very good at keeping up with them and providing responses as we went along. But we do have a few minutes so we can do a few questions live. I'll try to go through them so that we touch on each of the presentations and the projects again. Peter, I think I'll pick up with you. I'll start with you, and then maybe Stephen can add into it. We had a question about in the qualitative part of the study, did the practitioners provide any suggestions on increasing access, getting past some of the barriers for non-generic MOUDs such as Sublocade? So anything you got in terms of feedback that would be good for informing policymakers.
Yeah, so maybe Steve has more to say on this, but we didn't really hear much about recommendations along those lines in our interviews. But one thing we did observe is that the couple of organizations that were successful in prescribing buprenorphine were larger organizations that had more resources. They had larger billing staff, let's say, and people who could coordinate everything that was involved in getting the Sublocade. You have to do the prescription, then the patient has to I think speak to the pharmacy, and there's a couple different tasks that have to be accomplished. And so some of the larger organizations had the staff to accomplish all that. And so I don't know, it seems like it would be real difficult for small practices, but potentially, one potential solution could be just like strengthening those networks. Like New Jersey has its MAT RX model, so that if you have providers who do have the infrastructure to do Sublocade easily, just making it easy for patients to transition to those clinics.
So just to add to that, I think there's at least three important pieces that we need. I think Sublocade has not gotten enough attention. And when you have a crisis in retention, as we've all talked about, then in a situation where adherence is critical, then it's kind of a no-brainer that Sublocade ought to have a more significant market share. It ought to be a more viable alternative than it is. So number one is providing the cash flow so that providers can maintain supplies on site and not go through this crazy rigmarole back and forth with the pharmacies. Number two, most of the payers do have prior auth requirements, and they are not convinced it's a chicken and the egg problem that if there's not solid proof of increased effectiveness, then they don't want to pay for it. This medication is way within the zone that we pay for many other expensive medications routinely. So number two is the prior auth kinds of policies, and number three is just building the evidence on once again how does retention look compared to oral buprenorphine. So those are, I think, three of the important things. And then there's some subtleties about having a generic competitor, which the manufacturer has been trying to stave off for years, which hopefully will be entering the field.
Thanks, Stephen. Brad, a question for you. Thinking about fewer people seeking treatment, and do you think that rather than fewer people seeking treatment, the people are being turned away due to staffing shortages caused by the pandemic.
So let me be clear. I don't think there are fewer people seeking treatment. This to me is not a demand side. There's something going on the supply side here. In terms of being turned away, so again, funded by FORE, we're looking at sort of what happened with prescribers over that period. And I can tell you, at least in terms of buprenorphine, clinicians who prescribe buprenorphine, it looked like there's a gradual increasing trend of people prescribing. And it seemed to persist pretty much through the pandemic. We're not seeing lots of changes other than the change we've all talked about of NPs and PAs just shooting up dramatically and playing a larger role. So I don't get the feeling here that this was clinicians deciding I'm no longer going to prescribe buprenorphine, or clinicians who may have said I'm going to prescribe buprenorphine deciding not to. Could there have been workforce shortages of other people in their clinics that may have influenced how many patients clinicians treated? Sure. But I don't think it's sort of a workforce in fewer prescribers. Again, I think the most likely explanation I can come up and think of is that, again, most people who prescribe buprenorphine prescribe to relatively few people, and there's a handful who prescribe to a lot, right? And for whatever reasons, I don't get the feeling that either of these groups, in the face of greater need, decided to say, I'm going to double the number of people I treat. Why they decided not to do that, I don't know. It may have been they had like if you're a primary care provider, it's not as if you weren't busy, you had lots of other things to do. So there may be lots of other reasons. If I'm going to speculate, that's where I'd speculate, but this is something we're trying to dig in and look at. The other thing we're trying to understand more is this may vary a lot by sort of region and state. We saw tremendous, I didn't share with you, but there's tremendous state variation in some of these patterns that we're trying to dig into now and understand a bit better.
Brad, would you comment on, did you talk to prescribers at all about their willingness to initiate buprenorphine if on a non-in-person basis? So one can maintain treatment on a virtual basis, but if the prescribers in New Jersey, many prescribers, we were hit very early on, so many prescribers went virtual. And even though there technically was a waiver of the Ryan-Haight Act requirement for in-person initiation, if prescribers were hesitant to do that, that would be part of your explanation. And on the rear end, very specifically with regard to Medicaid, if you can disaggregate your reduced number of episodes ending, how much of it could be as simple as the temporary policies that stop discontinuing people from their Medicaid?
Yeah, so Stephen, so let me take those backwards. We're certainly digging into the payment issue now, because I do think sort of keeping people on Medicaid rolls may be critically important, and at least there's a signal in there as we look at the counting factors for total episodes. So we're breaking it down, looking at starting and ending episodes now. In terms of initiation, I actually have some colleagues that are doing a lot of work around telehealth. Lori Usher-Pines, if you haven't been following her work, is doing some great work in this space. And certainly she's been doing a lot of qualitative work and hearing from prescribers a decent amount of reluctance to initiate people on buprenorphine. And again, if you think about it, that may actually explain some of our broadband findings, because one way to interpret our sort of county broadband findings is those counties where you have the least broadband penetration, which may be a proxy for not really being able to do telehealth as well, really probably overall looked more like the pre-pandemic world than the counties where there was more broadband. So again, it's something we're trying to dig into, but I think what you're suggesting, you're probably onto something.
Great, thank you. We can get in a couple more questions. Let's see. Arjun, I know that you responded about the thinking about the community health worker navigator role in the ED, but I wondered if for the whole audience, you could just comment again on, you know, what your sense is of why that it seems to be such a critical component of improving any treatment or any of the interventions related to OUD.
Yeah, you know, I think there's a lot of successful models out there that are very dependent on having a community health worker or navigator or someone with lived experience who is really dedicated to treatment in the ED to really help with a few functions. One is supportive role on the screening side. Sometimes it can be facilitating discussions and conversations around treatment. Many are trained in expert methods. And then often it's also, most importantly, probably on the care transition side. These are people who have connections to a variety of community providers, can help create that warm handoff we want from the ED for people with treatment. The challenge has been this, that in the state of California, the availability of such community health workers through the Bridge program and a variety of state funds is much more ubiquitous. That's not the story for the rest of the country. And so we had always built sort of the offerings, the best practices, the tools of the E-QUAL network for EDs, assuming you don't have that. What we find interesting, though, is that despite the fact that we partner with the Bridge team all the time, and we have a low amount of California EDs in our program, other states, other places, other emergency departments seem to be identifying similar resources. Now, these are EDs that are choosing to participate in our network. And I think the reason is this, is if it was sort of obvious before the pandemic, it is strikingly obvious now that you need some extra help with the existing emergency department workforce to work in this space. We have basically broad nursing shortages. That's probably the biggest healthcare worker, and as well as tech shortages in almost any department in the country. And so what that's resulted in is these remarkably slim teams that are remarkably overburdened by crowding, boarding, case volumes. And so it takes time, effort, it's cognitively heavy and bedside heavy to do this work in the emergency department setting. And so the help and support you get from a community health worker or navigator essentially fills that gap for you. I'm hoping that as we emerge from this, we see new care delivery models where we can, you know, maybe even leverage telehealth in the ED, other things like that to provide that support and help so it's not on the primary ED care team, because we know their resources are too thin. But that doesn't require California level putting an FTE 24/7 in 5,000 hospitals in America, because I think that's just economically.
Thank you. Thank you. A lot more for us to delve into in terms of the role of a peer recovery coach, navigator, CD. I am mindful of the time. We did have one more question, Peter Stephen, that was about asking whether any of the lessons learned, including factors that facilitate or impede a system approach to policy development. That's a very big question for the final moment of the webinar. But Stephen, very quickly, anything you want to put out there? Maybe we can follow up.
Well, we need to be, number one, we need to be doing everything at once. So you take the cumulative effects of under reimbursement, prior authorizations that still exist in many places, the kind of supply issues, the ability to initiate buprenorphine at every touch point. And Arjun, I would love to see your 3% start going up to 10%, 15%. I think you need to think of it as an all hands on deck kind of thing, where all of the different segments, all of the policies that are barriers need to be done, not just one at a time, need to be removed. We're hoping that the X waiver will be one of them, and it will be facilitative of other changes. So the whole mindset has to be, we need to be doing everything, not just one or two things.
That's great. That's a perfect place to stop for today, and very good reminders for all of us. We will try to follow up with everyone on some of the other questions. I thank everyone for their participation. I thank the member of the audience who said, asked again about getting the slides and being able to replay it. Again, everything will be posted on our website. Hopefully by later this afternoon, PowerPoint as well as the recording. Most of all, I thank Brad, Arjun, Peter, Stephen, Victoria, our grantees, and the FORE team for this terrific webinar this afternoon, and we look forward to having more opportunities to interact with all of you in the coming weeks and months. Thank you. Have a good afternoon. Thanks.